Okay, we will go ahead and get started with our last talk for the day. I have the honor and privilege of introducing our last two speakers. First up will be Dr. Vivian Zhao. Dr. Vivian Zhao is a highly regarded clinical nutrition support pharmacy specialist at Emory University Hospital in Atlanta, where she's devoted 19 years to enhancing multidisciplinary nutrition support. As the program director of the only GASPEN-endorsed Nutrition Support Pharmacy Fellowship Program, Dr. Zhao plays a pivotal role in training the next generation of specialists. She is also actively involved in clinical research, serving as a co-investigator on multiple clinical trials related to specialized nutrition support. A member of several professional organizations, including ASPEN, BPS, and GASPEN, Dr. Zhao's contributions to the field include numerous publications and invitations to speak at national and regional conferences. And we also have a dietitian who I am particularly excited to hear from. She is one of our excellent team members on my team, Mrs. Libby Barlow. Libby Barlow has been a clinical dietitian at Emory University Hospital for the past 9 years. She's a member of the nutrition support team there as well since 2019. She also works in the cardiothoracic surgical ICU that specializes in the care of patients receiving ECMO. Libby also serves as an internship preceptor for our nutrition support rotation for our Emory University Hospital's dietetic internship. And we are very lucky to have both speaking to us today on vasopressors in the ICU.
Well, thank you for the introduction. We certainly saved the best for last, right? Everybody's still awake, right? Because there's going to be some pop quiz, so you better be ready, okay? So as Ashley mentioned, we're going to talk about enteral nutrition and pressors. I guess you guys definitely excited about that, right? All right, we have nothing to disclose. And here's the learning objective. I'm not going to bore you by reading it all out. It's in your handouts. You can review it yourself. So let's start our presentation with a patient case, DH. He was admitted to the ICU for cardiogenic shock, history of hypertension, hyperlipidemia, diabetes, you name it, right? And transfer from outside hospital with acute decompensated heart failure exacerbations, and then also sepsis secondary to likely Legionella pneumonia. Because of the escalating oxygenation requirement and pressor inotropes lead to intubations. And here are the medication that are currently patient is on, 1 antibiotic and 3 pressors. So we were consulted to start enteral nutrition. So the first question come in mind is that is it safe to feed, right? So let's see, test your knowledge. You can grab your phone, you can scan the QR code, or you can join us in the vvac.app and then do the ID and pick your answer. I'll give you a couple minutes. So the question is, which statement reflects current evidence regarding enteral nutrition in ICU patients receiving vasopressors? A, all patients on vasopressors should receive PN only. B, EN is associated with universal risk of mesenteric ischemia in ICU patients. C, we should delay EN, which will improve outcome in vasopressor-dependent patients. Or D, EN may be cautiously initiated in patients on low to moderate vasopressor dose who are hemodynamically stable. All right, I'll give you another minute or so. You got all your answers in? Oh, let me initiate. That's kind of weird. All right. Maybe if I hit this, would it go? It wouldn't go? It's still in the welcome page? On your slides, it's still on the welcome page? I guess technology didn't work out so well with it. All right, well, but I guess by the raise of hand, how many of you think is A? Nobody, okay, good. B? All right, C? All right, D? All right, some hands. So let's see if we're right or wrong, okay? So in the 2016 SCCM and ASPEN guideline pretty much addressed that question. Is EN safe during the period of hemodynamic instability in adult ICU patients? The answer was in the setting of hemodynamic compromise or instability, EN should be withheld until the patient is fully resuscitated and or stable. Initiation or reinitiation of EN should be considered with cautions with patient undergoing withdrawal of vasopressors. And in a more recent guideline that published by Aspen in 2022, the guideline didn't really address the question specifically related to pressor. It actually addressed the EN-related clinical outcomes such as high versus low dose of energy dose, high, low protein dose, exclusive isotonic EN versus PN, and enteral nutrition alone versus supplement PN plus EN. But although they didn't really adjust pressors, I mean, I think all of you in the room would agree with me that all the patients that included in those study there, they all receive some sort of pressor, correct? I mean, it would be amazing they don't need pressor at all. So I guess that kind of gives you a little answer. It's like, hey, maybe it could be safe. And in the same year, in 2022, Aspen also published a consensus statement, which actually specifically answer when to initiate early EN in hemodynamically unstable patient, which it says vasopressor administration is not a contraindication to provide early EN as long as you have careful monitoring. Okay. So in order for us to really initiate EN safely while patients on vasopressor, there are 6 key factors that we should consider, which is type of vasopressors, the doses, the timing of EN initiation. Those are the 3 that I will cover. And then the last 3, which is feeding tube locations, enteral formula, and then also ongoing monitor will be covered by Libby. Okay, so let's start with the type of vasopressor. Who is ready to memorize everything on this table? All right, so this table is not really made it for you to memorize it. It's really just to show you that all the vasopressors actually works on different receptor in your body. And then the plus and minus side, the next minus side means that they have no affinity to that receptor. The more plus side means that they have more affinity to that preceptor. So obviously you're seeing the different affinity with different pressors, so which the effects might be different, right? And then I also listed dopamine at the bottom. As you know, this is not technically a vasopressor, it's an inotrope. However, in high dose, which is when it's greater than 5 microgram per kilogram per minute, it actually acts like a vasopressor. Okay, but aside from that, the main thing I want you to remember, Willie, is that vasopressor kind of shunt the blood to the heart away from all the other organs, like the GI tract, right? So that's the only thing I really want you to remember, okay? Not the rest of them. So as demonstrated in this table, if you remember earlier slide, because of different receptors, so the effect on your body is different. However, the common theme is that you can see decreased GI blood flow. And the main concern for us is necrosis. However, the reported incidence for necrosis is less, it's about 1%, so it's pretty low. And one of the questions I always get is that, does different ICU patient tolerate, why do they tolerate tube feeding differently? I kind of trying to break it down. There's honestly no study really showing that, oh, surgical ICU patients tend to not tolerate tube feeding as much as medical ICU and whatnot. But I tried to attempt to see if we can kind of dissect it a little bit, right? So I have separated here surgical ICU, medical ICU, and cardiovascular. Norepi is the first line of recommended by the SCCM guidelines, so it's remaining as the first line. However, you can see some differentiation from the second line and refractory treatment from the medical ICU and cardiovascular ICU. So if you put it all together, right, so in all the vasopressor decrease GI blood flow. However, when you go into the medical ICU or cardiovascular, they actually start using some inotrope agents, which is showing to kind of somewhat increase blood flow. So it kind of maybe counteract. However, the degree of the impact is nobody knows, right? But that's merely a suggestion. So it'd be nice for us to have some sort of study to answer that questions. Now that we got all the basic information down about vasopressor, what about dosing? That definitely plays a role in how it might impact our patient. And here I kind of list the common dose range for initial dosing and typical dose range once it titrate. And this is merely for your reference. I see most of them, you guys might be dietitians, so I don't expect you to know the dosing. One thing that I do want to point out to you is that as majority of the vasopressor are dosed by microgram per kilogram per minute, except for vasopressin, which is dose in unit by minute. Okay, but when you're looking at all those different doses, I mean, the first thing is like, how do I put everything together? Because some of the patient, they're getting different medication. I don't know what it really means, right? So we do have a standardized scale that we use. A lot of them for critical care, and you do them for research purposes to kind of assess the overall vasopressor exposure. It basically converts the dose of various vasopressor into a single equivalent to what a norepi is. And I kind of list some of the ratio and suggestion there, but the formula here, you can see the norepi, and you kind of add up everything at the ratio. So who actually, pharmacists here actually get this formula memorized, and you can just pull it out. I can't, right? So I do tend to use some helps to remember how to remember this. So yeah, pop quiz time. If you want to pop, no, I'm not going to do this to you. But what's DH noepi dose equivalent, right? Because the main thing is we get consulted, is that safe to start, can we start EN on this patient, right? So first we need to know how much patient's actually getting. One way for me to determine the noepi dose equivalent is I technically pre-built a Excel spreadsheet, so which is kind of like this. If you want it, I can email it to you. But that will, I mean, I can't memorize it, like I said. And this is also easy. You just plug in a number and it will give it to you, right? And the other way is, how many of you actually know open evidence? Well, actually uses it, okay? You can have AI to help you out. Okay, so if we're plugging all the numbers, and so those are the doses the patient's getting. So basically DH is getting about 0.47 microgram per kilogram per minute. And if you were to using the open evidence, you pretty much type in, it's just say calculate the norepi dose equivalent for, and you list all that, you got the same exact answer. Right? So even if you're not really savvy in building your own Excel spreadsheet, you can use open evidence. So again, does this number really mean, right? 0.47, what's it going to tell me? Well, this number actually helps you to tell you that is the patient going to tolerate tube feeding or not? Okay. In one of the retrospective study included 259 ICU patients, which is showing this chart here. The study actually conclude that the patients are more likely to tolerate EN if the vasopressor dose equivalent is less than 12.5, in around 12.5 microgram, and versus the patient get about 19.4 microgram per minute. So for our patient, based on this study, our patient might not be able to tolerate it really well, right? Similar finding was also found in a retrospective study that includes 120 patients. This chart is kind of a little hard to see, but as you can see, the patient that received a lower dose of norepi equivalent actually seems to tolerate EN better. And kind of summarize it together is that what they conclude is that 70% of the patient tolerated tube feeding if the dose is less than 0.14 microgram per kilogram per minute, and only 30% of them tolerate if it's a higher dose. And you hear me talk about tolerability a lot. So what do they really mean by tolerability with the study that they looked at? So the intolerance is actually related to emesis, GRE greater than 250 to 300 ml, abnormal imaging finding, bowel proliferation, mesenteric ischemia, and obviously lead to all those other ICU complications. So the main thing we're really concerned about is really mesenteric ischemia, right? Because the rest we can kind of fix, but mesenteric ischemia was kind of concerning. So who is actually familiar with the 2 Nuturia study? Okay, yep. Okay, so the two Nuturia studies, the 2 biggest enteral nutrition EN study. For Nuturia 2, which included 2,410 patients, literally they're comparing to EN versus PN with the same calorie. And as you can see, the incidence of bowel ischemia is 1.6% in EN compared to 0.4 in PN. And whereas the Nuturia 3 includes over 3,000 patients, and then they pretty much testing low calorie versus high standard calorie. And the incidence rate is 0.9 in low calorie and 0.18%. And as you can see, the chances for ischemia is still pretty low, right? Some of the contributing factor that lead to bowel ischemia is if the patient receiving a median dose greater than 0.5 microgram per kilogram per minute, so which is considering a higher dose, and then a rapid EN rate in it, titration, and then lack of monitoring. So to put everything together, and then so just for as a summary slide, you can see patients generally are safe and well tolerated if the dose is less than 12.5, and versus if they're more likely to tolerate if it's less than 0.14, and then there's increased risk of ischemia if it's greater than 0.5. And essentially, it's higher the dose, higher chance of ischemia, less likely to tolerate, right? All right, so let's kind of go back to our patients. So as I said, the dose equivalent was 0.47. So what's the considering safe or at least tolerate is 0.4. So our conclusion would be not likely to tolerate EN, right? But that doesn't answer our questions like, can we start? We know they won't tolerate. That doesn't mean we can't start, right? Can we or can we not? So when should we really start? With the timing of the EN initiation in the same study that I presented earlier, they actually look at the patient who started EN within the first 48 hours, and which 78% of them actually tolerate EN. Compared to the patient that start after 48 hours, there's only about 48% of them tolerate it. And with the current ASPEN guideline, the recommendation is to initiate EN within the 48-hour of ICU admission if the patient are with control shock requirements, small or moderate dose of pressors. MAP have to be greater than 60, and then you can do low dose EN. Or you can initiate within 48-hour vasopressor based on the dose, and then which they use it as a vasopressor dose equivalent as VDE, so which is that what you will see from ASPEN guideline. But how do we what is EDE, right? So this is another different equation that you need to memorize, right? No, you don't. So the multiplier is different than what you've seen earlier. But the main thing is the scoring will help you determine if you should start or not. So with the VDE that's greater than 12, the general recommendation is you either do trophic, keep it at 10 ml an hour, or you're actually going to hold the PN. And when there's more definitive answers, when you should actually delay or hold is, I mean, obviously the patient being actively resuscitated or unstable, the score is greater than 12, then you can consider whole or like previously say trophic. And then you do MAP. If the MAP is less than 50, then you should definitely hold. So back to DH. So what's patients in VDE? Like again, I'm not going to make you calculate. So I did plugged in my little Excel sheets. So the sum of the VDE score for this patient is actually 47. So what do you actually notice? When we're doing the dose equivalent, it's 0.47, right? So technically, if you know one, then you know the other, right? So based on the scoring, so this patient definitely not safe to start, correct? You all agree, right? Okay. So now back, and then him remaining in ICU on day 5 and day 6, the dose for his pressor have like decreased to 0.1 to 0.02, so it's dropping. And then the VDE and then the norepi dose equivalent is 0.22. So it's lower, right? MAP is 65. So what would be the most appropriate action? So let's give you the choices. I know this one might not work. I'm sorry. Technology, right? So the question, so I will have you guys just read through and then give me the answer or think what you think it is, okay? So which of the following is the most appropriate action regarding EN initiation for DH? A, delay EN until vasopressors completely discontinues. Begin trophic EN via gastric feeding. Initiate full EN via post-pyloric feeding, or switch to PN due to vasopressor. So who says A? B? Okay, C? I, D. All right. So technically the correct answer is B. All right, so I'm gonna change, keep the podium to Libby, and then she will tell you why your answer is right or wrong.
All right, so now that Vivian has reviewed the different types of vasopressors and how their dosages correspond to appropriateness to feed enterally, we have some decisions to make as practitioners as to how best to feed these patients. So some things we're going to consider are where to feed, so either gastric or post-pylorically, what formula to feed, how much to feed, and then what are some tools for ongoing monitoring for these patients. So according to this retrospective review that was done in 2013, which looked at the safety and tolerance of enteral nutrition in patients fed gastrically and post-pylorically, the authors found that enteral tolerability was higher in patients who were being fed into the stomach compared with post-pylorically. Adverse events or signs of intolerance that were noted in this review include an elevated serum lactate, which we'll talk a little bit later about maybe not being the best marker for enteral tolerance, emesis, elevated gastric residuals, and a 0.9% instance of bowel ischemia was noted. This later study was done, which looked at the tolerance of just gastric feeds in patients who were requiring vasopressors who met the criteria for sepsis, finding that gastric feeds were overall tolerated about 62% in this patient population. Elevated gastric residual volumes greater than 250 mLs was the most commonly cited instance of intolerance. And when we compare the rates of gastric tolerance in these two studies, perhaps we can conclude that tolerance rates were lower in this study because our patients who meet the criteria for sepsis are typically our sicker patients. And we know that the sicker the patients are, the more inclined they are to have some issues with tolerating enteral nutrition in general. When deciding where to feed, it's also worth considering which feeding tube location may or may not be associated with a higher risk of mesenteric ischemia. As Vivian noted earlier, mesenteric ischemia is kind of our big sign of enteral intolerance that we worry about. And while incidence is very low, the mortality is very high in these patients, upwards of 50%. So I think it's definitely something worth considering and talking further about. Based on the research that we have available, however, it's really difficult to say for certain which feeding tube location is associated with more gastric ischemia. And that is because we have a variety of studies that use different types of formulas. They use different calorie and protein amounts. They use different pressors. They use different pressor doses that they include. However, what we do have is that a majority of case reports where enteral nutrition has thought to be strongly associated with causing mesenteric ischemia has happened in surgery, trauma, and burn patients who were fed into the jejunum. Based on what we know about the anatomy of blood flow and the fact that the small intestine is distal to the stomach, potentially we do have greater opportunity for mesenteric ischemia when patients are being fed into the small bowel during periods of hemodynamic instability. So before we get into different considerations for our enteral formulas, let's just get a baseline of what you all would do for our patient DH at this time. So let's just raise our hand to answer the question, which enteral formula characteristic is most appropriate for our patient DH at this time? Who thinks a high caloric density formula would be most appropriate? What about a high fiber formula? Low protein or polymeric? All right, so most of us think polymeric. So let's get into the different types of enteral formulas and whether they may be more or less indicated in this patient population. So there are several different considerations when it comes to our enteral formulas. We know that more so these days than ever, we have a wide variety of enteral products that are available for our use. So one of the things that we'll consider is volume or caloric density of our enteral formulas. We have formulas starting at the 1 calorie per ml range and going all the way up to the 2 calorie per ml. We're definitely going to look at the patient's overall volume status. We know how common volume overload is in the ICU, and we know that it can really cause a host of problems, especially vent weaning in our critically ill patients. So certainly some patients may have stronger indications for volume concentrated formulas than others. We also tend to know that some patients do better on lower volumes of more concentrated formulas, and some patients do better with higher volumes of less concentrated formulas. It can be very individualized based on tolerance. We're also going to look at patients' renal function when we decide how much protein we want to give with our tube feeding. We have formulas that are low in protein, standard in protein, high in protein to pick from. Fiber content is another consideration that we will evaluate, especially especially because how common both diarrhea and constipation tend to be in the ICU. We've got fiber-free formulas, mixed fiber, and soluble fiber formulas that are available. Lastly, we'll look at polymeric or standard formulas compared with our semi-elemental or peptide-based formulas to see if one type is more or less indicated in our patients who are requiring pressors. In reviewing some research studies that have specified which formula concentration have been used, we see that a variety of different formulas have been used with varying results. Most often, a 1.0 to a 1.2 calorie formula has been cited as being used. Some things to point out from these selected studies. In 2018, our target trial compared a 1.5 kcal per ml formula with a 1.0 calorie formula, finding increased GI symptoms and hyperglycemia in the 1.5 kcal per ml group. And then in Mansell's 2013 review, which we talked about earlier when we talked about feeding tube locations, there was a 0.9 instance of bowel ischemia, and these events did occur in 3 studies, or in 3 cases, excuse me, and they occurred at all different feeding tube formula concentrations, 1.0, 1.5, and a 2.0 kcal per ml concentration. We talk a lot about protein in the ICU, and while we know the importance of adequate protein in this patient population, are there advantages or disadvantages of higher or lower protein amounts in our patients who are requiring pressors? So it's thought that higher protein formulas may generate a hyperemia effect to increase oxygen delivery to the gut, but the effects of this really aren't clear. What I think practice and where research is headed in the future is going to be looking more at the timing of the dosing of protein, especially in the first week of ICU stay. So from the ProteinVent study, they found that the best outcomes were associated with a low protein intake the first 2 days of ICU stay, which was defined as less than 0.8 grams per kilogram. Followed by a moderate protein delivery, about 0.8 to 1.2 days, about 3 to 5, and then a high protein intake greater than 1.2 grams per kilogram after day 5. And this was again associated with a lower 6-month mortality. The thinking behind this is that higher protein early on in critical illness may lead to inhibition of autophagy, which in turn leads to ongoing cellular damage and dysfunction. Next, we have fiber. So the proposed benefits of enteral fiber include normalization of bowel function, improvement in diarrhea, especially with the addition of soluble fiber, and promotion of healthy gut bacterial growth with benefits to the gut microbiota and gut barrier function. The risk with enteral fiber seems to be associated, especially with our insoluble fiber, thought to increase stool bulk, which may put direct pressure on the bowel wall mucosa, leading to impaired mucosal blood flow, resulting in bowel necrosis, from the increased demand for blood flow combined with a metabolically stressed bowel. According to our 2016 ASPEN recommendations, they suggest avoiding both soluble and insoluble fiber formulas in patients who are at high risk for bowel ischemia or severe dysmotility. But the criteria for those things really is not well defined, and this is of low quality evidence. Lastly, looking at our polymeric or standard formulas when compared with our semi-elemental or peptide-based formulas. It's thought that the peptide or semi-elemental formulas, because they contain these small peptides and predominantly MCTs, they're thought to be easier digested and absorbed, resulting in improved GI tolerance. They're also thought to result in faster gastric emptying, promoting better intestinal motility and nutrient delivery to the gut, thereby resulting in reduced risk of intestinal ischemia due to less gut oxygen consumption required for the digestion and absorption of these enteral formulas. However, recent studies haven't shown a consistent benefit in the use of these semi-elemental or peptide formulas over polymeric or standard formulas when it comes to gut ischemia or improved GI tolerance in our patients who are requiring pressors. Now that we've talked about the different components of enteral formulas that we'll consider, we didn't have to decide how much we're able to feed our patients who are requiring pressors. And to really understand this, I think it's important to review the phases of critical illness to get a better idea of exactly what's going on in the body, especially during that first week of ICU stay, because that's going to really dictate our patients' ability to tolerate and utilize the nutrition that we give them. So first we have the early acute phase, usually marked by the first 1 to 2 days of critical illness. This phase, there is common metabolic instability, electrolyte derangements, circulatory shock, respiratory distress, catabolism, and GI dysfunction is very common during this time. Then from days about 3 to 7, our acute late phase period, we do have some stabilization of these various metabolic disturbances with ongoing catabolism and potential for significant muscle wasting. After about the first week of ICU stay, patients tend to take one of two directions. The first is that of rehabilitation, especially when it comes to physical activity, disease process, and nutrition status. On the other hand, we all know the patients that tend to be our chronically critically ill patients that just seem to sit in the ICU forever, who have ongoing inflammation, immunosuppression, and catabolism. Let's now take a look at what 3 recent large-scale studies have shown and how these results may help determine calorie and protein delivery in our patients requiring pressors. So first we have the EFFORT protein trial that was feeding patients at a fairly conservative calorie amount, about 13 kcals per kg, on about 0.2 of norepinephrine equivalents. This study looked at whether higher or lower protein would impact clinical outcomes, and they defined lower, more so standard protein, about 1.2 grams, compared with higher protein, about 2.2 grams. The results of this study showed that higher protein doses did not improve outcomes in the ICU, specifically time to discharge alive, and that higher protein doses may actually be harmful in patients with greater disease severity marked by SOFA scores and also patients with acute kidney injuries. Vivian spoke a little bit on our Nuturia trials, but next we have the Nuturia 2 trial. Again, like Vivian mentioned, these patients were being fed on pretty high doses of pressors. Nuturia 2 looked at early enteral nutrition, prescribed at what they considered standard or full nutrition of about 17 kcals per kg, compared with parenteral nutrition. This study found that there was a higher incidence of GI complications in our enteral nutrition group, and that potentially because there was about that 2% incidence of bowel ischemia in the enteral nutrition group, that in fact full nutrition in the first week of ICU stay in patients requiring this high doses of pressors may be harmful. Lastly, we have the Nuturia 3 trial. Again, these patients were being fed on pretty high doses of pressors considered by most. The study looked at low protein and calorie delivery compared with their standard protein and calorie delivery in ICU patients. This study found in the low-dose nutrition group a trend towards improved ICU mortality, faster time for weaning both pressors and the mechanical ventilation. It also found in the standard nutrition group more instances of enteral feeding intolerance, refeeding syndrome, and volume overload. Based on the results of these different studies and several other smaller studies that have really echoed these results, it's likely that we have a theoretical sweet spot for feeding our patients on vasopressors, and this probably depends on disease severity, timing, and nutrition dose delivered. So what are our current recommendations for how and when to feed in the ICU? So this chart includes both the GASPEN and ASPEN guidelines. We can see from the GASPEN guidelines, it's recommended to initiate enteral nutrition early, but hypocalorically, progressively increasing to standard nutrition or tube feed goal over the first week of ICU stay. And they target about 1.3 grams per kilogram of protein, again, delivered progressively. Our ASPEN recommendations are 12 to 25 kcals per kg in the first week of ICU stay, gradually increasing to goal nutrition over about the first week of ICU stay based on clinical judgment, with a 1.2 to 2 grams per kilogram protein target. So while there are some minor differences in recommendations, I think where we're really moving towards is a less is more approach to feeding these patients, especially early on in critical illness. Back to our patient. So vasopressor doses remain stable on ICU day 6. So we were hitting about the week mark where we start to think about enteral versus parenteral, risk versus benefit of both things. So we felt that it was appropriate to start trophic feeds in this patient. We started at 10 mLs per hour. We did initially pick a low protein formula for this patient, but that was primarily because the patient was on CRRT and their ammonia level was close to 200 even on CRRT. So the patient was kept on trophic feeds for about 24 hours before the critical care team thought that it would be appropriate to start advancing the patient to tube feed goal, which they did over the weekend, advancing the patient by about 10 mLs every 6 hours. At follow-up, we followed this patient very closely, and as this patient had improving improving ammonia levels on CRRT, we then transitioned the patient to a higher protein formula. So ongoing monitoring is going to be really, really vital in these patients who are requiring pressors and who are receiving tube feeding in our ICUs, because we know how dynamic these patients can be, and we know how quickly a patient's clinical status can change day to day, or even hour to hour at that. So enteral nutrition, when should we adjust or withhold enteral nutrition? It may be considered in some instances. And again, this is really going to be just a guideline and up to clinical judgment ultimately. So if a patient is requiring new types of pressors to maintain their hemodynamic stability, or if they're requiring increased dosages of existing pressors, that might be a situation where we take a step back and reevaluate our enteral plan. If a patient is unable to maintain their mean arterial pressure greater than 60, that might be a situation where the patient is not hemodynamically stable for whatever reason, and it may be worth holding our enteral nutrition at that time until further evaluation. Many of us know that routine monitoring of gastric residual volumes is no longer recommended in our patients. There is low quality evidence to suggest holding for elevated residuals greater than like 250 or 300. I think when we are doing this, we certainly want to consider the patient overall. Certainly if they have some elevated gastric residual volumes and they're also having some changes in their hemodynamic stability, or they're having other signs of GI intolerance, it may be worth reevaluating our enteral plan. Finally, lactate levels are not recommended to use to monitor enteral tolerance, and that's because serum lactate levels are inconsistent before the onset of bowel ischemia, and elevated lactate levels may actually occur in response to already existing bowel ischemia. We know that there are many other causes of elevated lactate as well in the ICU, including sepsis, shock, trauma, hypoxia, hypoperfusion, and bleeding. Certainly, we want to also use some of our more traditional signs of GI tolerance to guide our enteral plan in this patient population. So signs and symptoms of enteral intolerance may include abdominal distension, new severe abdominal pain, significant nausea or vomiting, a sudden decrease in the passage of stool, gas, or absence of bowel sounds, increased nasogastric tube output, an unexplained metabolic acidosis, which may indicate bowel ischemia, and radiographic signs including dilated bowel loops, air in the wall of the GI tract, or portovenous gas. So in summary, enteral nutrition is not contraindicated in our patients requiring vasopressors. We do want to evaluate the type and the doses of our vasopressors being administered to determine the appropriateness of enteral nutrition. Careful monitoring is essential when these patients are receiving enteral nutrition and vasopressors in order to detect any signs of enteral intolerance early on. Some quick takeaways when we're making the decision of when and how to feed these patients. When to feed, we can tend to feel comfortable initiating enteral nutrition within 48 hours if our VDE score is less than about 12. Where to feed, gastric feeds are likely most appropriate in the majority of our patients. What to feed, again, up to clinical judgment a lot of times, but according to research, a 1 to 1.2 calorie per ml formula seems to be generally well tolerated. Higher protein is probably fine, especially if we're not, feeding a patient at 100% of their goal nutrition, the first couple days of ICU stay. And then a low fiber formula or a fiber-free formula as well that's either semi-elemental or peptide-based, polymeric seems to be well tolerated. And then how much to feed. I think we can be comfortable starting our trickle feeds about 10 to 20 mLs per hour the first 1 to 2 days of ICU stay, gradually increasing to goal within about the first week. That is all Vivian and I had for today. Does anyone have questions for either of us? All right.
I have a
No.
quick question
Yeah.
I'll ask. So it seems every year we come to these conferences and every year we say something different about gastric residual volumes. So should we be checking them? Should we not? What is your take on that?
That's a good question. I think most of us are not checking them. Certainly, it seems that there's some patient populations where providers feel more strongly about that. Specifically, like in our surgical or transplant ICU, some of the providers want that in their patients. I think that in the absence of other signs of enteral intolerance, they're not a great indicator of enteral tolerance. But I think considering the whole patient, so if you're trickle feeding a patient and you check their residuals and they're 300, that might mean that things aren't moving. That means something a little bit different to me than if we're feeding a patient at 85 mLs per hour and they have, 250 mLs of residual. Well, they probably should have something in their stomach if we're feeding them that much. So to answer the question, it might be something different next year, but I think we're moving more towards at least a global GI assessment where we're asking nurses to not just look at gastric residual volumes, but evaluate for our other signs of enteral tolerance at routine frequencies.
So I guess just to add to that, part of it is not really to keeping checking the GRV is not really for the purpose of GI intolerance at times. For some of the hospitals do want to keep that protocol as is really have a task for the nurse to actually truly assess those patients every 8 hours just to make sure the feeding tube is not dislodged somewhere. So it's sometimes it's really not checking it for the sake of checking for intolerance. It's really make sure the tube is still in place.
So follow-up question to that, how would you know your tube has been misplaced? Well, how does the gastric residual volume get used in that situation?
So it's not really the volume tell you that it's misplaced because when you actually go and do the gastric residual volume, you actually check the tube. They not usually have a indicator where this exit site is at, so you know if they're being inward, you don't see the line anymore, or being pulled out. So it's more of that indicator instead of the actual the volume. I mean, if you think about if you actually check my gastric volume residual right now, I might have a liter because I just drink a lot of liquid, right? So how's that really helping you? But it's just keeping a task, that, especially in ICU patients, that the tube is in the right place.
Thank you.
Great. Thank you all. Have a great weekend.
You have a question?
I was just gonna say, how do you? What? When you're talking about low fiber formula or fiber-free formula, what are you typically using and what do you consider low versus medium? Because a lot of formulas now have moderate to higher volumes or amounts of fiber. So in these patients who are on, pressors and it's a little iffy, what is your level of fiber that you're willing to accept, or what do you feel more comfortable with?
I don't go for an actual fiber amount. I don't think that there's great guidance as to what that is. I probably am not allowed to name specific formulas, right? No. Okay. So typically I will lean towards a fiber-free formula or a product that's just containing soluble fiber. The short chain fructoooligosaccharide blends, I think, tend to be pretty well tolerated. And the formulas that tend to contain those without naming any specific names also tend to be like our semi-elemental or peptide-based formulas. So I think because in theory, those things contain components that are already partially broken down, that makes me feel better about using the soluble fiber. So to answer your question, I would love if there was like an amount that I could point to and say, but.
And also in regard to increasing your goal, your last point about trophic feeds within the first 24 to 48 hours, gradually increasing the goal in 7 days. So that's a total of 9 days that it takes you to get to goal. I mean, do you think you should be doing some supplemental TPN during that time if they're not progressing?
Yeah, I would say usually we tend to aim to reach goal by the 7 days. So trophic feeds within the first 48 hours. And then from there, we've got about 4 to 5 days where we're increasing to goal. And then that kind of gets us to that 1 week mark where we're like, all right, the patient needs TPN if they're not tolerating their tube feeds sufficiently.
Excellent. And we have a question online.
Cool.
Do you normally combine trophic feeding with parenteral nutrition? So if they're, I guess if they're maintained on trophic feeds, hey, doctor, and do you add lipids or do you?
Great.
Well,
Great question.
So just ignore, but you
Yes.
could do that next year.
Would I love to do that in most of my patients? Yes. I think in our surgical ICU, we do a little bit better job of identifying patients who we know are not going to be able to tolerate
Right.
goal nutrition in the first week. And then that patient population, at least at our hospital, I think we do a decent job of right away, we're starting both. However, in like our cardiothoracic surgical ICU, our MICU, we're struggling. It's an uphill battle. I absolutely think there are patients that would benefit from that. But it's, an ongoing conversation we have with our critical care providers and our surgeons, especially. And we would do lipids. We would do lipids in that patient group.
Awesome. Thank you.
Yeah. Is there any other questions online, Allison?
That I think I see everybody. That's it.
All right. Now have a good weekend.